Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echovascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, I have the awesome privilege of talking with one of my dear friends, Bridget Winchester. She is a queer prenatal genetic counselor at Minnesota Perinatal Physicians with a line of health in Minneapolis, Minnesota. She graduated from the University of Minnesota in 2020 with her MS in genetic counseling. Bridget is a current member of the NSGC Task Force on Reproductive Access, Freedom, and Justice. She is involved in the disability community as an MNLEND fellow and a sibling to an adult with Down syndrome. She is current chair of the Minnesota Genetic Counselor Association, MNGCA. Her published research focused on motivational interviewing and improving familiar risk communication. Please help me welcome Bridget Winchester. So today I thought we'd talk about some Down syndrome. I'm here today with Bridget, a genetic counselor, and just wanted to share a few facts about Down syndrome first. The English physician John Langdon Down first described Down syndrome in 1866, but the characteristics of the condition have been allude to the centuries in art, literature, and science. He is considered the father of Down syndrome for this accurate description and the condition as a distinct entity. Some other key events in history of Down syndrome: 1838, psychiatrist J.E.D. Esquirrel was the first to write a phenotypical description of trisomy 21. But it wasn't until 1959 that Lejour, ETAL, confirmed that the suspected association of Down syndrome was a chromosomal anomaly. Then in 1968 was the very first antenatal diagnosis of Down syndrome, which I think is fascinating, being that I was born in 1970, so I don't consider that very old.
No, it's true. The goalpost has moved a lot in the last several decades, certainly.
So in 1983, it was shown that the low maternal serum alpha-fetoprotein was associated with Down syndrome. And the numbers for Down syndrome are estimated to be about 1 in 700 babies are born with this. So it's approximately 0.14% of the population. It is estimated that around 200,000 people in the United States have Down syndrome at this present time. And Down syndrome is considered the most common condition in the United States. Let's see, Down syndrome occurs in all people of all races and economic levels. The risk depend a lot on the mother's age. However, 80% of babies with Down syndrome are born to women under the age of 35.
I feel like that's the fact that always surprises people.
Right, exactly, right? So I think that's an important fact, though, to remember as an ultrasound technologist, though, because you're scanning and you're thinking, oh, they're 25, 26, 27, they probably won't have, findings. However, they might have findings,
Right.
So it's always good to be kind of on your toes, regardless of the age of the patient, for these things, and to understand that ultrasound only picks up 50% of them. So ultrasound is not that great at picking up specifically T21, which is Downs, right?
Yeah.
So the latest and the newest is the non-invasive prenatal testing, the NIPT, which was discovered in 1988, and it was introduced in 2011. which is really interesting that it took that long to really kind of introduce it to the public. First rolled out to Hong Kong and then was made more available to other countries. So I think it's the opinion of the American College of Obstetricians and Gynecologists that all pregnant people be offered the NIPT, regardless of their age or the risk, which is the most recent and up to date. We didn't used to offer any kind of genetic testing to people under the age of 35. And so now with this new NIPT, it's nice that we can offer it to anyone.
Yeah, and we did offer serum screening, like maternal serum screening was been recommended for the last couple decades to everyone. And so that would be like our traditional first trimester screen. So that report that you noted with like AFP or alpha fetal protein levels. So doing all of those like markers, those had always been like recommended for everyone to choose. It's certainly historically lower levels of uptake have happened in populations under 35. A lot of that is to your point of bias. I think a lot of patients are unfortunately misinformed that like, oh, you're young, you're not going to have a baby with Down syndrome.
Right.
And certainly the risk is low, right? Like it's not
Right.
like it's going to 100% happen. And I think we should be appropriate about the level of risk and concern. But I think certainly it is incredibly common for postnatal diagnosis to be with young moms, particularly because of that. Whereas at most of the cases of patients over the age of 35 are getting screening done. I think, and now commercial payers are paying for it for everyone. I think there's like 1% of plans in the US that don't typically cover it for everyone without like a risk reason. And so I think that's definitely exploded a lot. And I think the big shift, even to young people really liking screening, has also been because with non-invasive prenatal screening or like the overall technology cell-free DNA screening, it does allow for, looking at our X and Y sex chromosomes. And so a lot of families jump at the gun at being able to find out, sex of baby as soon as possible. And countless times they'll end up, in my office after wanting to find out sex of baby and having a whole nother result come up. And so I certainly think that's popularized the test even further. And, and I think unfortunately, because there's so much that happens at those initial OB visits, that it can
Right.
certainly be something that's only addressed for a minute or two. And because of that, we can have, unexpected results come, which can be kind of disorienting and stressful for a patient.
Right, which really kind of brings in the specialty of high risk OB, right? Because how often do we bring patients in and they're so excited to see their baby and we're excited too after we find out things are normal, right? And
Yeah.
I'm glad that you don't know that all the many things that could go wrong. But on the other hand, I wish there was a little bit more, and I'm sure other sonographers wish there was a little bit more understanding of our jobs and the fact that, it's a place where things can happen that really shift sometimes the future of your life,
Right.
in regard to the health of the baby.
Yeah.
So yeah, I think I've often referred to the ultrasound room as like holy ground, right? Like we're either gonna leave this room with some reassuring information at this point in time, or we're gonna give you some information that is gonna take you down a rabbit trail sometimes,
Yeah. We never know until we get there. And
but we
I
don't. And
Yeah.
that's the unknown, right? And that's the whole holding space for that information to kind of come along. So in the high risk OB ultrasound units that I've worked at, the ones that have on-site genetic counselors such as yourself is so valuable to be able to hand them off immediately to someone who's knowledgeable to help them kind of work through this new information that they were just given,
Yeah, and certainly, of course, I'm biased being in the field, but I do think that there is a lot of value because I do think it, particularly in genetic counseling, I think we're kind of trained with like two main focus, and it's kind of in our title, genetic counseling. We have a focus in genetics, but we also learn a lot of psychosocial and counseling skills, and that's pretty much half of our education, and so in training, and so we learn a lot of frameworks, and we unpack a lot of our own bias and do a lot of that training, and Obviously, to some extent, each individual genetic counselor has to do some of that on their own too. But I do think that that can be really useful, because not only can we give information, but also the ability, I think, when we're dealing with a prenatal case, is that everyone's coming into this ultrasound, usually with like one thing on their mind. They want to find out boy or girl, and they're excited and they want to get pictures of their baby, which makes
Right.
sense, because pregnancy is this kind of like, you don't know really what's going on, until you start feeling the baby, and things like that, that there is this gap. I feel like a lot of patients are like, I had a dating scan at 6 weeks and now it's 20 weeks and I don't know what's even happening.
Right.
Even though it's kind of our standard framework for sonography, I think a lot of patients don't realize that the purpose of sonography is to identify, birth defects, identify things that are wrong, or rule out things, right?
Right.
Versus it's not just like, oh, here's your first photo of your baby.
Absolutely.
Exactly. I think unfortunately, that can be really tough and high risk, as if people are coming in, even if it is like the only indication is advanced maternal age. And if something completely from left field comes in, I think it can be quite disorienting, because that's definitely not the side of pregnancy that you hear about as much.
Right. And I think it can be traumatizing sometimes, right? Like hearing that you have a baby who has a defect, and trying to process, how is that going to play out, and how is that going to affect our family, and how is that going to affect us moving forward financially? All these things that kind of go through your mind when something does come up on ultrasound. And I appreciate your mention of bias, because, we certainly all come to different things with different bias based on experience or religion or culture, our culture that we were brought up in. And so, yeah, I think even bias training for ultrasound techs, might be even advantageous,
Yeah. I've always been amazed that you guys don't have as much like training in that sphere of it, just especially thinking about, what you guys do in high risk pregnancy. There you are with a patient, and yes, not every patient can read an ultrasound, perfectly. I mean, could not. But there are some defects that are obvious, right? Or it's very clear that something is wrong,
Right.
or they're not hearing a heartbeat. Those are all things that I think, but they might not be able to point to every organ on the scan. Patients know when something's wrong, and I do
Right.
always feel for you guys, because you guys are in the room really unable to do much, besides kind of rely on your own skills for managing that emotion. And I do think that you guys end up in those scenarios more than maybe your training really highlights.
Yeah. And I think sometimes it's our job as sonographer to just kind of make room for the possibility. They're so excited, and so, which is awesome. I mean, we're glad that you're excited.
Yeah.
I don't want to take that away from someone, but sometimes to help set a mood or a environment for the doctor to come in, is there's some things I'm seeing on ultrasound I'm not really sure about, and the doctor will begin to talk to you, something of that kind of a statement to hopefully help prepare them. Some people pick up on that, some people don't, so I think that's just based on experience, some of the things I've learned, but I've never had bias training. Right. And so talk to me a little bit about that, because I know from when we're speaking of trisomy 21, your own personal experience and maybe bias with that, and counseling someone without that.
Yeah, we talk a lot about, do like countertransference, particularly, and like transference, which are generally terms we use in like the psychology space to kind of describe how we can be impacted by our patients or clients. Essentially, the countertransference is kind of placing your emotional history onto a patient, whereas transference is kind of the opposite relation. And so those are things that we definitely talk a lot about, and do a lot of role plays and training to allow us to also, a big part is take care of your own mental health and your own ability to process, because you are dealing with high emotions and with, potentially someone's worst day of their life. And, you may never be able to see them a year from now when, things are okay again. You may only be seeing them at that moment and never again. And so I think we all have to take care of ourselves too, in that kind of, because I do think, burnout and compassion fatigue are big issues and concerns in, kind of all of the medical space, but especially when you're dealing with, anomalies or, unexpected findings, being able to kind of be aware of some of those phenomena and kind of keeping it in your back pocket as like, is this patient, reminding me of something? Where are my emotions at with this patient? Am I able to kind of, walk with them? We talk a lot about in genetic counseling, like walking with a patient down a tough road, but not carrying them. And that just really kind of speaks to, trying to develop that healthy relationship where you're able to support and have empathy for patients continuously, throughout your career without burnout and without starting to just place bias, I think, on patients. Because I do think, a symptom of burnout that we don't think about is, using shortcuts in our brain to try to like, okay, this is what's going to happen, assuming, XYZ person's going to do this one thing based on previous experience. Our brains love to do that. That's, our brains love patterns. And so I think it's something we have to actively kind of work against, because while there might be overarching patterns in the world, every person is so unique. And every diagnosis that I've given of Down syndrome has been unique. And I think I've helped families, really with every option that there is, and I think for me, having a brother with Down syndrome, what was hard initially when I was training was I was personally afraid that, I don't have any personal qualms with termination in a lot of settings, even in medical settings or non-medical settings. And so, I knew coming into the space that wasn't something I would have to wrestle with particularly, but I was worried that when it came to Down syndrome particularly, that maybe that would emotionally, kind of just grate on me throughout time. And I've really been, I think, reassured and been lucky in the last 4 years of my career where I feel like it really hasn't impacted me in the way. And I think I never thought I would go into prenatal initially because I was worried, but I had great supervisors in my training who pushed me, who said, you're ready, you can give this diagnosis, like you can do this without being biased. And so having that kind of support in your training too, and being able to be open and honest, like, this is my family history, this is where I come from, I'm worried that this might impact how I'm giving this news. And so I think that really, like, that self-awareness and just reminding yourself of that is so useful outside of even kind of more formal training for bias and things like that. But I really would say I never have an issue with kind of what patients end up choosing for their families, as long as I feel like they're making an informed and good decision. I think that I'm more worried in the cases where someone is like, Down syndrome won't change our life at all, than when someone, is able to wreck it with a full impact of it, because it is a lifelong condition. And, we can't tell by genetic testing if, your baby is going to be, on the top end of that spectrum with, very mild intellectual disability, or if they're going to be, in the moderate, more, even on that severe end where we're, nonverbal. We have, kiddos who require 24/7, care, and other kiddos that can live in group homes, so there's lots of different levels of effectiveness. And I think in the world and in media, we see the milder versions, like all of the, there's like reality TV shows. It's called like Down for Love or something. I watched it, but it was on Netflix. But there's like reality shows about adults with Down syndrome and dating. And it's great that we're seeing all that content, because, it's amazing to where we've been since, when, I forget if is it Dr. Down? I don't know if he's actually, assuming he is a doctor just because probably at that time and space, but, when he first described it in that kind of very clinical language that we used, that now I think if you read back, and I have read his original report, you would be like, this does not sound how we would talk about Down syndrome in our world today. And I think we've shifted a lot, which is great. But I do think there is a lot of different opinions about Down syndrome because it is a common condition people have heard about. And so for me, the biggest thing is always just making sure that we can meet with those families and give them, the information or resources to make that choice and make that decision. And so I feel like a lot of my training kind of full circle here kind of has just kind of helped me also kind of keep in check and keep those, keep it from really affecting me in a way where I feel like I'm getting too burnt out from it. And I did also do, in my own training, there is a fellowship called Leadership in Neurodevelopmental Disabilities. Yes, that's the LEND. So it's a LEND program throughout the whole US. There's different centers that do it. The University of Minnesota is one of the LEND centers, and they take fellows from several different spaces. So genetic counseling being one of them. There's usually people in all different forms of healthcare. There's like family and self-advocates, people in speech language pathology, list goes on, and so it's a really interdisciplinary group that did a lot of bias training about how we talk about neurodevelopmental disabilities. And I think that program was particularly really helpful for me, because even though I was coming in, I think with a personal side, I obviously am biased by what my brother's Down syndrome looks like. And so it is helpful to, kind of hear other stories and learn, about other people's experiences, because there isn't just one, there isn't one Down syndrome. There isn't, it just like any human, there's a wide variation. And so always important to, I think, keep that open mind.
Yeah. And I can appreciate what you mentioned as far as like walking alongside of them. Much of the journey of an ultrasound tech too, we kind of keep a close eye on via their growth on ultrasound, any baby that has any kind of aneuploidy or trisomy. And so oftentimes I've been able to kind of walk alongside some of these patients and getting the initial news, and then them coming back and not just doing their ultrasounds, but kind of just checking in with them. Like, how are you doing with this news? And, different things. And they'll say, well, we're getting used to it. We're getting more information. The genetic counselor is helpful to give us, that. And we're kind of settling into the idea of it, So I've walked alongside people like that. And then I've also, one thing that really changed in my career, or helped me to understand in my career, is a young woman came, and her baby had multiple soft markers for Downs. She did not want to do any kind of genetic testing. We did follow her through her pregnancy, where those markers became more visible and more of them the further along she got through her pregnancy. And she delivered. It was Down syndrome. The baby did go to the NICU. However, they would not do any further surgery or anything until that genetic testing was done. So they knew exactly what they were dealing with before going into surgery. And I had the privilege of seeing her, like, I want to say 3 or 4 years later, where she came back to the same clinic with us with her second pregnancy. And then she wanted every test known to man, And so I asked her, I said, do you mind me asking why the change, why the difference? And she said, if I would have had that information before I delivered, then we could have treated him sooner. He sat in the NICU with high dollar prices of the NICU, right? For almost 2 weeks.
Yeah,
right?
So that testing takes, usually 2 weeks at rush. That's rush testing.
Yeah, waiting for the information. And if we would have had the information up front and honest, we could have been more prepared and dealt with things as we wanted. And so she really came into her ultrasound with the idea of, you just want us to abort the baby. We're not going to do anything different. We get it. We don't want you to do anything, that you're not really willing or wanting to do with your pregnancy, but just how important it is to just have that preparation.
Yeah. And I think that's a really common story. If you look at the literature, any data set that talks about, the difference between prenatal and postnatal diagnosis, every single paper I've seen, there is a significant advantage to a prenatal diagnosis. Now, to your point, for some people, and I've certainly had families where they feel like, just dealing with, all the appointments and the anomalies and the change in, care can be overwhelming. And they're like, this information will be better for me later. Now, that's a great reason. And I think you're being very thoughtful of like your family and your scenarios. But I think the misconception that, genetics is for termination or that's our goal, I think is something I wish will hopefully, kind of dissipate as time goes on, because I think many genetic counselors feel how I do, where really our goal is for people to make informed choices. And I strongly believe that if you're not comfortable, helping families make independent and different decisions than what you would make, then it's probably not the field and space for you, because people are going to do different things than what you would do. Very rarely are they going to do exactly what you would do. And that's because we're all unique. And I really think that, Down syndrome is a great example, but almost any genetic condition has the same, story where prenatal diagnosis is really helpful. And even some, moms and families do say that, sometimes it is really nice that after a diagnosis, people stop kind of saying congratulations. They stop being excited about the pregnancy. And so I think that can be something people are also kind of hesitant about, is losing some of that excitement. And so it is something, and obviously there are settings where we don't say congratulations. There are settings where we say certain things and not, right? You use your judgment. You can't do, one shoe fits all, but there are cases where I think it can be really, really useful and helpful to meet a family where that's at and be like, you can still be excited. We have a lot of planning and maybe now there's NICU involved, but we can still be excited that you're having a kiddo. And so I think keeping that in mind is, I think it's hard when people, I think, do assume that we're coming in the space to say that, we think that you should terminate. Because I quite simply have never told a patient that. In fact, I have, that is something I would never say to a patient, because I truly think that, termination, every single patient I've helped has made a very tough decision, and a decision out of love. And for some people, that decision out of love looks different, but it doesn't mean one is right or wrong. And I think it's really important for us to also think about the other benefits of genetics, which is, that planning and preparing, and not just, making a decision on your pregnancy.
Right. Yeah, I think it's such a multifaceted event, I think, when it comes to ultrasound and being faced with some of that, holding space for people's emotions and feelings, and then holding space for our own judgments and our own biases. Like you said, I personally had an experience with the Down syndrome when I was a child. Our neighbor was a 40-year-old Down syndrome man, and he had mentality of maybe a 10-year-old possibly, but we played together, and he was very respectful and he had a schedule. And so Down syndrome has played a really important part in my life, as just how important they are to our society, in general, and the differences that they do make for us as a society. So I appreciate your conversation with us in regard to this and your role. I appreciate that, and how you've handled so gracefully. I've seen personally how you've handled so gracefully so many patients. And I appreciate, genetic counselors are so important, and sometimes prepping us as ultrasound techs. Like, they just got this information. Here's what, you need to look for. And this is kind of where they're at in that mental space, And so us as ultrasound techs being able to come into that ultrasound scan prepared and with knowledge is so vital as well. So we thank you for that. And we thank you for all the people that you do educate and inform and walk alongside of. So one question I'm wanting to ask, because the name of the podcast is, it's all about your frequency. What one thing do you do that increases your frequency on a daily basis?
Well, that is a great question. I think for me, as silly as it is, I feel like I am an adult that still loves to do arts and crafts. I feel like crafting is something that I go back to in different phases in my life. I am no super talented artist. I work in science for a reason, but I do love there's something I think about, whether it's painting, I've done pottery classes, or, I do crochet and things like that. So there's a couple, hobbies I feel like I do. And I think there's something really beautiful about crafting, because it is so different than what I do on a day-to-day basis. It's very, physical with your body, and it kind of does allow me to get out of my head. And particularly with pottery, the thing I loved about doing it was when you're, throwing pottery on the wheel, it's very easy to make a mistake. You can be working on something for 30 minutes and then wiggle your finger wrong and it is done. And it's humbling. It is incredibly humbling. But it is also, I think, just it was such a great lesson to kind of continue and have in my life, because I can be a perfectionist. And so it is just helpful to sometimes, have these small hobbies that are, kind of reinforcing all of those positive kind of just, ways of thinking, that, things are not permanent, things change, and that we can restart and we can make mistakes, and all of those lessons, I really think that they are in crafting. It sounds silly, but I do think that it does really always help, with just me being able to come to my full self for clinic and everything, is having the time to create something that's so different than genetics, that's just completely separate, I think is really healing and helpful.
Awesome. That's great. Well, thank you for your time. I appreciate it.
It was lovely chatting with you.
Yeah. How's everybody else there doing?
Pretty good. I did get another chat that I probably have another ad on later, so
yeah,
but not bad.
Awesome. Well, thanks so much. I appreciate it. Is it still okay to use that same bio that you sent?
Yeah, I think that should be fine. Yeah, I don't think there's been probably anything too significant, so should be good.
Awesome. Perfect. We're going to start September 4th, and I'm hoping you're going to be one of the first, because I thought this would be a great way to start it out. So thanks.
It's exciting. All right, we'll talk to you soon.
All right.
Later. Bye.
Bye. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.